All right. Good afternoon, everyone. It's really great seeing you all with another academic session. Today's topic is initial stabilization of a critically ill patient. And our resource person is Dr.Senitha Liyanage, Consultant Emergency Physician at Emergency Treatment Unit of Colombo Teaching Hospital. Dr. Senitha graduated from the Faculty of Medicine, Colombo, with honors, followed by 15 years of experience in critical care, including ICU, anesthesia, and emergency medicine. MD in emergency medicine in 2016 as the first batch of Sri Lanka, and followed by MRCEM at UK. Apart from that, he holds postgraduate diplomas in critical care medicine and disaster management, as well as the certificate for competency in anesthesia. He is a well-experienced speaker in both national and international conferences, as well as an internationally accredited instructor in ALS, POCUS, APLS, hospital preparedness for emergencies, and many more. He is the past president of Sri Lanka College of Emergency Physicians, the past treasurer of College of Palliative Medicine of Sri Lanka. Without further ado, let me welcome Senitha to commence the lecture. Over to you, sir.
Thank you very much. Hope you can hear me. So this is another episode of a new topic of initial stabilization of a critically ill patient. As doctors, we are working in our own specialty. It can be emergency medicine, or can be medicine, surgery, pediatric, psychiatry, or any given specialty. We are meeting daily a lot of patients, and even our private sector as well. And no doubt, we all have dealt with a critically ill patient. We are mostly comfortable when you see a patient in our own specialty. As example, if you are working in obs and gynae unit, we are happy with the obs and gynae patients. But sometimes we might get another different type of patients. As example, if a bystander, an adult patient, can get collapsed, it is completely different from the obs and gynae management. Even during visiting hours, there can be small children comes and stay with the patients or looking the patients, looking their mom. That child can have any emergency or any critically ill condition suddenly develop. Maybe foreign body aspiration, maybe anaphylaxis, maybe allergic reaction, maybe a faint, vasovagal attacks. So we should be competent enough to manage a critically ill patient at any given content. So this 1 hour or so, we'll see how we can establish a critically ill patient stabilization with a very structured way. I know all of you have managed critical ill patients so far. You have some competency. So my exercise today is to arrange it all in a structured way. You can manage that patient easily. I'll give a case. So you are in a doctor in your medical unit. You are getting a 45-year-old male with thinking he's having some drug overdose. We don't know what is the medication. You are maybe the only doctor on duty, and no other history is available. Patient has gone into a seizure while coming to a hospital, and he is now drowsy, looks pale, sweaty, central cyanosis, and evidence of vomiting, and he is saying snoring of respiration. This is not an uncommon presentation. For my emergency department, I'm getting this kind of patients at least 10 a day. So I'm quite sure you might encounter such patients in your life, or maybe in near future. So we'll see how we are going to manage such a patient. We don't know much history. We don't know the diagnosis. Only we have a patient. So we do something. Before we are treating, we have to save his life. So we all know the patients are dying of the altered anatomy and altered physics. Our aim is to fix the anatomy and the physiology as much as possible to save the life and delay the death. In this presentation, I will what is this research protocol, initial stabilization form. You can see it is in the middle of the screen, the emergency management of the serious ill patient. There are 5 steps. We'll go each and every. If you have any questions, feel free to ask or drop the text in the chat box. We'll assess and address all the issues at the end of my presentation. So my aim is to give a generic method of why generic method. So when we come to a seriously ill or critically ill patient, we don't know the diagnosis first. It can be a STEMI, it can be any anaphylaxis. So whatever the condition, if we have a generic method, we can act immediately and save the life. We call that generic method the research protocol. That is the key thing in my lecture today. As I mentioned previously, if you have a generic approach, it is very easy to learn and easy to recall under stressful condition. When we have a critical ill patient is really unstable, maybe going to die. So you are in much alert, and all the staff in the ward may be watching you. And not only that, the patient's party, the patient relations, or maybe the other patients in the ward might checking what my doctor is doing to stabilize this patient. So we all in some sort of stressful condition depend on your experience and how much you have dealt with such patients. So it's really important to have a generic approach. That means a common approach to any patient who are in a critically ill condition. So this is the research protocol or generic approach which I'm talking so far, that is having 5 stages: the triage, initial stabilization, then we go for direct history and examination, and then we start the specific treatment and ongoing care. Those are the 5 steps in the research protocol. This is the traditional medical model we are using each and every day. First, we take the detailed history and we think what are the possible differential diagnoses. We narrow down those things by the physical examination and we do the investigations. Depending on all, we start the treatment. But this traditional medical model is not appropriate for a serious ill patient, because patient will lose the life when the diagnosis comes, because if you don't do the treatment. By keeping all in our mind, we'll go to the research protocol which have the 5 steps. The step 1 is the triage. The triage is the thing we do each and every day in our hospital. Even you are also doing it in your day-to-day life. As example, if you are working in a busy ward, if you come in the morning to see the patients, you always first give the priority to see the patients who haven't seen so far, because we don't know is there any patient who are critical ill among the patients who are not seen. Then we go to the patients who are in the acute cubicle. Then we go to the chronic patients. So always we are sorting our patients according to the level of urgency, in aim of giving appropriate time, appropriate area, and appropriate staff with the appropriate equipments. So that is the safe and efficient management of the patients. First thing is the triage. So if you get patients in our department in Colombo, we are seeing more than 300 patients a day in our A&E. With the 92-bed A&E, we always do the triaging all the patients and the presence of the triage desk, or the very first desk, which is dealt by the nurses. In the triaging, we are having 5 categories. In our setup, we take it as the 4 categories. That means we take this 5th one separately. So category 1 is the patients who are dead or dying. We need the resuscitation. We have to see that patients immediately. So category 2 is the patients who are in emergency, maybe time critical illnesses like chest pain suggestive of acute coronary syndrome, any stroke patients, maybe testicular torsion patients, or maybe neutropenic sepsis. We need immediate management. Category 3 are the patients who are ill but not belong to category 1 and category 2, but patient is ill looking, can't walk, we look bit of ill. Category 4 are the patients who are walking, talking patients, which come to the accidents and emergency or to the ward to take the treatment. Category 5 are the non-urgent patients. That means elective admission, such as that patient is seen from the clinic and advised to admit another 5 days time or maybe 5 weeks time to the ward for elective procedure. So those are the non-urgent patients. So when we have a resus patient, category 1, the doctors and nurses should see that patient immediately. And with the category 2 patients who are having time critical illness, we should see that patient within 10 minutes of the hospital admission. And category 3, you can see within 30 minutes, and category 4 within an hour. That doesn't mean that we are spending time without seeing the patient, but this is the time break. We should see within this time. We always consider PPE, the personal protection equipment, from the days of COVID, but we should consider in the presence or the absence all the time. We should care ourselves. We should wear PPEs in an appropriate way. We should not go with the rabbit kit all the time, but depending on the contaminant, depending on the degree of exposure, you can decide rationally which level of PPE we are going to use, because the safety of the healthcare team is a must. After the triage, we are going to step 2, we call it initial stabilization. The first part is the position. That's also important in our patient care. So, if the patient is dyspneic patient, we never let the patient lie down on a bed. We keep the patient propped up always, otherwise patient will die or critically worsening his condition. If the patient is a pregnant mother, we keep the patient on the either seated or on a lateral position. We'll never keep the pregnant mother on a supine position, because the aortocaval compression by the gravid uterus will release the venous return, and that reduces the blood pressure. And also, if the patient is a pediatric baby or child, we never take the patient and put on the bed. The patient is alert and active, because that patient will be utterly distracted and you will be never able to examine that patient. We always keep a child on the lap of the parent or the guardian. That is the most comfortable zone for that particular child. So first thing, we do the triaging. Second, we stabilize the patient by positioning in a correct manner. Then, going for our all ABCD: airway, breathing, circulation, disability, and the exposure. We'll see what are the key principles here behind this ABC. So airway always comes about the breathing, and not because of the alphabetical order, that because of the priority. Or if you ask from any lay person, if you're going to kill your enemy, how you're going to kill? He never tells that I'm going to step on her back. This is, I'll squeeze your neck. That means each and every person, even lay person, they know if someone obstructed the airway, that is the quickest killer. And if the airway is obstructed, no point of checking the breathing, because if there's no air comes into lungs, you couldn't hear any single breath sound. If the breathing is not there, no point of checking circulation because heart will stop anyway. If there's no circulation, no point of checking disability because brain has no perfusion. So therefore, definitely GCS will be low. In this concept, we have key things to memorize, keep in our memory. First thing, what can kill the quickest, which I explained previously. That is how ABCD order has come. So we have to assess the airway and treat and then go. It is also very important. So we'll stop if the step is not working correctly. As example, if the airway is obstructed, we identify the airway is not patent. No point of going for breathing unless you correct the airway. So make the airway patent and then go for check the breathing. If the patient is not breathing, then optimize the breathing. You might start under ventilation or some other measures and optimize the breathing, then go to check the circulation. Likewise, if any step is not in a proper way, you stop there, treat it, and go to the next step. Other key thing on ABCD is if you're checking the airway, if the airway is patent and then patient's breathing is fine, circulation is fine, you are checking the GCS, GCS is also fine, and you're going for the exposure. At that time, if you noted patients become deteriorates, always stops there, go back to the airway. Likewise, if the patient deteriorates suddenly, always check from ABCD. Is this patient has patent airway, breathing is fine, and how the circulation. Likewise, go to the first section and come down quickly. So we are going to start the airway. When you go to see the airway, you can see in this picture we have oral cavity, that is oral airway, and the nasal airway. What makes the airway obstructed? In an unconscious or semi-conscious patient, always lose the muscle tone that leads to the tongue drop backwards, and that presses the airway and that obstructed the airway. So tongue falling back is the most commonest reason to have obstructed airway. Apart from that, there can be secretions, maybe saliva, maybe vomited, maybe food particles, or it can be foreign bodies. Anything can obstruct the airway. Or if in a trauma, or in a normal person, dentures can obstruct, or tooth particles, whatever a matter that can obstruct the airway, we have to clean it. If you have any airway obstructed foreign body, never ever do a blind sweeping. You can't put a finger into a patient and move that fingers in a way that cleaning the airway or taking the foreign body out. That can lead the foreign body dislodge further in, which making much more difficult to take them out. So always in the hospital, use a Maggie's forceps. Very easily you can open the mouth and grab that foreign body and then take them out. And other commonest way is the suction devices. We can use a Yanker suction. We can easily suck out the secretions on the oral cavity. Then, how we are going to deal with the tongue falling back? The tongue falling back can be dealt by the head tilt and chin, which I mentioned in this screen. So head tilt and chin lift, that leads the fallen tongue away from the airway. That improves the airway patterns. But there's a small drawback. If the patient following a trauma, which is a significant mechanism, or the spinal damage can be happen in a significant trauma with a high risk mechanism. In those patients, we should not do this head tilt and chin lift that can further harming the partially damaged cervical spine. So instead of head tilt and chin lift, what we do is the jaw thrust. I haven't mentioned how to do the jaw thrust here, but we have very good YouTube videos on these head tilt chin and chin lift technique, as well as the jaw thrust technique. After optimizing the airway, we are going to the breathing. So on the breathing, what you're going to check? First, we'll check, is this patient breathe? In that case, if the patient is breathing, what is the breath rate? We can check how much of work of breathing this patient is taking. If the patient is in the proper position, the tripod position, and fixing the breathing with using accessory muscles, and you can auscultate and see whether the lungs are clear, and you can see any added palpitations, run time, those kind of things. And also you can check how the breathing is adequate by measuring the saturation level. And also in the pediatrics, we can check the flaring of 𝗦𝗨𝗕𝗦𝗖𝗥𝗜𝗕𝗘, and we can check for the any intercostal recessions, subcostal recessions, or the suprasternal recessions. Those are the key things on the breathing assessment. So this breathing assessment is not equal to a day-to-day respiratory system examination. Here it is a very brief and quick assessment, but that not replacing your good old respiratory system examination. This is a very quick thing we are doing to fix the life within a couple of minutes. After fixing the circulation, after fixing the airway and the breathing, now we are moving to the circulation. The circulation, what you're going to check? We are going to check the pulse. We check whether we can feel the pulse. And what is the pulse rate, pulse volume, whether it is regular or irregular. And first we check the radial pulse. To see the radial or feel the radial pulse, at least the patient should have systolic blood pressure of 80 millimeters of mercury. But if the patient is collapsed, no good cardiac output, you might not be able to get the radial pulse. In that case, you have to take the carotid pulse. To feel the carotid pulse, at least that patient should have systolic blood pressure of about 70. And another important part is the capillary refill time. Without any instrument, we can easily do this capillary refill time. It's quite objective. We can press the nail bed of the thumb on an adult patient and keep it pressing for 5 seconds. We can count the 5 seconds even without watching at the pace of a watch. Count by 2,000, 3,000, 4,000, 5,000. At the end of the 5,000 counting, you can release the pressure on the thumbnail and again start counting 1,000, 2,000, like how many seconds that patients take that blanching of the nail bed disappear the blanching patch. That is how we are checking the capillary refill time. It's very objective, easy to do, but you have to do it in a proper way. And if you are in an exam, in a clinical exam, where the examiner checks, are you doing it capillary refill time in a correct technique? Please count it in a way that examiner can hear that, because it's almost all the time it's a marking point. And also we should attach the patient to the cardiac monitor to check the ECG, whether the sinus rhythm or any VF or VT or asystole like rhythms which need the CPR, always at the detection of the circulation. Next, what you're going to do, we check the perfusion and we optimize it. How we are going to optimize? We need the IV cannula. Always think which size of cannula we are going to put. That depends of which kind of fluid we are going to give, what is the rate that you are going to give. As example, if you think your patient is an adult male who is having some septic shock, you are going to give the fluid. Our normal IV fluid is normal saline for any patient who is in a shock. How much of saline you are going to give? Always we ask, give a bolus. Then people ask, how much of the volume? How soon we should give? That's a very common question. Normally, if a patient is not having any heart failure, not having any renal failure, the patient is not a very old person, might having poor physiology reserves, patient is not in dengue shock, patient is not a DKA patient, patient is not a neonate. Other than all that groups, we can give 20 ml per kilogram. If the patient is an adult, we take the body weight as 50, so our fluid bolus should be 1000 milliliters. It is a big amount. So therefore, in a healthy adult, bolus will be the 20 ml per kilogram, 1000 ml, that is 2 normal saline bottles. But patient should not having any DKA, not should having the dengue hemorrhagic fever, not in heart failure, not a geriatric patient, renal failure patient, because sometimes their fluid responsiveness are limited. And then, how soon we should give this 1000 ml? That depends on the size of the cannula you are using and the vein patency. If you are using a green colored cannula with the size of 18 gauge, the manufacturing company mentioned what is the maximum flow rate you can achieve. That mentioned in the each and every packing of the cannula. Normally, if you take a 18 gauge cannula, maximum flow rate will be 95 ml per minute. That means if you have a cannula in green color in a hand, we can give the fluid bolus. It takes 10 minutes. If you put an ash color cannula, 16 gauge cannula, the flow rate is somewhere around 200 ml per minute. So therefore, you can give the fluid bolus within 5 minutes. The limiting factor most of the time is the size of the cannula and the vein patency. That is why in trauma patients, we always ask to have 2 wide bore cannulas, because the trauma patients, the losing fluid component is the blood. We have to give the blood and blood products, because we can't compensate the losing blood by giving simply normal saline. So if you give blood, you know it's quite thick, high viscosity. So color cannula, that 100 ml per minute is for normal saline or any fluid with low viscosity. If you start blood, that fluid rate goes further down. And once you put the cannula, the appropriate size, the appropriate place, first do the blood test. We should never forget to do the blood sugar levels from the cannula. No need to have an extra or additional prick at the capital level. We check the blood sugar from that particular blood, so we can have the venous blood sugar levels. And also, we take the blood test in an appropriate way. If the patient is collapsed, unconscious, or any other fitting or whatever condition, if we have the blood gas, take that blood to do the venous blood gas. It's quite appropriate bedside test, but unfortunately it is not available all the time. But that doesn't mean you can't proceed from that without doing that test. But if the patient is having diarrhea, fever, you get his full blood count, electrolytes. Likewise, in the patients, you should take the blood for grouping and GT and those kind of tests as well. So always the test, but never ever forget the blood glucose levels. And the type of IVF fluids, they are depending on the clinical condition. The patient is having hypovolemia or hypotension, always you use the resuscitation with normal saline. We never use 5% dextrose to improve the circulation, because it never improves the circulation, because once you give the 5% dextrose to the patient, The dextrose will metabolize. You left with the only water. That water will go into the interstitial space and the intercellular space without leaving any much volume in. So therefore, always in the shop, use normal saline or Ringer's lactate to improve the blood circulation. So after fixing airway, breathing, and circulation, now we are going to check the disability. The disability, we always know, we check the pupil response, the pupils are equal or not, and the pupils are reacting. Next thing is the Glasgow Coma scale. We check what is the GC of this patient. So GCS, that carries three components. One is eye opening, and then verbal response, and the best motor response. So in the adult, you can keep in mind what is the GCS scoring system, but that varies on the pediatric age group. On the infants, we check different way. Neonates, different scale, different components, and toddlers, different way we check in the GCS. So GCS, very important among the patients who are having head injury. That matters what is the outcome of the patient. That matters the patient can maintain the airway patency, whether we need to intubate or not, and how soon we have to intervene. Everything depends on the GCS score. But it is not really practical to check GCS for each and every patient who are not having head injury or not having any intracranial pathology. So we are using AVPU scale to check if the patient is alert and walking, talking normally. That equals GCS of 15. That is alert patient. Second group is B. B is the patients who are responding to voice. The patients is keeping their eyes closed, but when you talk to them, they talk. That means GCS is slightly reduced, maybe 13 out of 15. There's another patient group. They never respond to the verbal commands, but if you apply some pressure on the sternum, then patient get response. So therefore, that patient group is the patients who are respond only to the pressure. We call AVPU the P group, that the GC is somewhere around 8. If that patient you need to transport, always think fixing of airway, because patient is too much drowsy. He is unable to maintain the airway by himself. The last group of the AVPU scale is U group, that means unresponsive patients, that GCS is around equal to 3. Tone is very important in pediatric age group. If the baby is carried by the mother, if baby is quite silent, and if you carry the baby, the all legs and hands are floppy. That means poor tone. It is actually a pre-terminal sign. In my A&E, I'm quite happy to see a patient who can vigorously cry rather than sleeping on the parent's hand, because the patient is calm, quiet, sleeping, can be due to worsening of the illness. So make sure the baby is quite active and energetic. So we have to the initial stabilization. We did triaging. We did the initial stabilization that carries positioning, airway, breathing, circulation, disability. The next part is the MMR. MMR is the measure, monitor, and reassess. So the measures, we have to check the temperature, and if you forget to check the sugar levels, do the capillary sugar levels, and if the patient is having hypoglycemia, the blood sugar is less than 70s, the patient should receive IV dextrose. When we are giving dextrose intravenously, we have two preparations. or maybe 3 preparations. We have 50% dextrose, 25% dextrose, or the 10% dextrose, and we have 5% as well. So correction of hypoglycemia, we commonly use 50% dextrose or 10% dextrose. Different colleges, different countries have different argument, which is more superior, which is less superior. So up to now, there's no research find which one is superior. Which I find is both have good as well as drawbacks. If you are using 50% dextrose, we can correct the hypoglycemia by using roughly 50 ml of 50% dextrose. That quickly increases the blood sugar level. The drawbacks are that rise the sugar levels much quicker. They can give more sugar to the brain, patient will awake quickly, and is quite concentrated solution that patient might get thrombophlebitis because of the high osmolality. So always, once you use 50% dextrose, should have some sort of IV fluid to dilute that way the thrombophlebitis. Next thing, if you use 10% dextrose to optimize the hypoglycemia, we have to give 10% dextrose, roughly about 200 to 300 milliliters. So if you are giving equal amount of 50% dextrose 50 ml, that means 10% dextrose 500 ml. If the patient is quite old, poor cardiac function, that volume can be bit of overload. So always use cautiously in clinical manner which one you can use, but better to go by your unit policy. And once you give correct dextrose hypoglycemia by giving dextrose, always make sure that you should check the blood sugar levels in the regular interval, because there can be a reason of hypoglycemia. Commonest reason is patient is diabetic, has taken the patient's hypoglycemic agents, but not taken the proper meal. So therefore, that patient, if you give dextrose, that will improve the sugar level very transient, because the medicines that we have taken to reduce the blood sugar is keep on acting. So therefore, we have to maintain the sugar infusions, maybe 5% dextrose, or it can be dextrose saline, that means DNS. We are giving maintenance dose, and always encourage patient to have a complex carbohydrate meal that will digest and continuously release the sugar to the body, that you can overcome the repeated hypoglycemic events. And always, we should not forget to monitoring the patient. You should check the ECG, you can do the saturation levels and the blood pressure level. Those are the monitoring part. And also, never ever forget the reassess. Always reassess the patient. As example, if you correct the oral airway by putting oral airway, we check, do we really need the oral airway further? If the patient having breathing disorder, if you give the oxygen, and check, does this patient need further oxygen? And if the patient is having bronchi, and if you nebulize the patient at that time, check whether you need to give another dose of nebulization, and always reassess. And if the patient is hypovolemia, if you correct it by giving IV fluid bolus, check how the pulse rate now, how the blood pressure now, how the completed time now. Reassess and see whether you have to further correct, whether it's completely corrected, whether it's partially corrected, or whether it's not corrected at all. So once you completed the triaging and initial stabilization, now it is the time to do the direct history and examination. So this is the first time we are asking what has happened. Then you will wonder, I took roughly 50 minutes to explain ABCD to you all and how to do it in a correct way. But in real life, we can do it within seconds to the minutes. So it is not that time consuming. which I explained so far, because I did it very slowly and in a way that which can clearly grab by yourself. Do you check ABCD of each and every patient? Just think. Do you check ABCD of each and every patient you are assessing? Yes, we do. When we talk to a patient, "Hi, what has happened to you today?" The patient will tell, "Doctor, I have a terrible headache with cough and cold." At that time, patient can talk to you nicely in a single sentence in a good pace. That means that patient's airway is patent. And that patient can take a good tidal volume to talk in a single phase. That means breathing should be normal. And that patient gives a good rational answer. So that patient in the erect position or seated position or standing position, the blood pressure should be in a reasonable way, and GCS should be 15 out of 15. So we are checking ABCD each and every patient you are encountering in subconscious way. But we are checking ABCD on each and every step separately if the patient is unconscious or semi-conscious or delirious. Right? So therefore, we have to do those things only if the patients are critically ill. But we can do that resuscitation in two ways. One is the horizontal way, otherwise the vertical way. The vertical way is the one I mentioned previously. Check first airway, then check breathing, then check the circulation, and then go to the disability. If you have a good team, if you have good teamwork, like in Formula 1 car race, you can do the horizontal resuscitation. Take your team, nominate this doctor and this nurse goes to the airway doctor and the airway nurse, and this doctor and this nurse the circulation. So airway doctor can look after airway and breathing both. The circulation doctor and the nurse can put the cannula, connect the monitoring and stuff, and other one will be the team leader. Likewise, if you divide yourself among your team, you can do the horizontal resuscitation, which can do the fixing of the patient within few minutes. Maybe 2-3 minutes is good enough. If your patient is having fits or the convulsions, are you going to do all these steps before giving IV midazolam? Yes, we do. As I mentioned previously, when the patient is fitting, we take that patient quickly to the resusc bed. That is, we are triaging the patient. We stop all other works and all the team comes, and all the team means the adequate amount of team come and start the treating the patient with triage. And the airway deal by one health person. One person take the cannula insertion and another person preparing the midazolam. So we all do ABCD and assessment, checking the patient's sugar levels, because hypoglycemia is one of the notorious factors can cause fitting, especially among small babies. We do ABCD first, then I'll give the IV midazolam to stop convulsion. The anaphylaxis. Are we behave the same way? Yes, we do. First, we'll take the patient with us. We position the patient. We never keep the patient on a seated position because that can be deteriorate very fast. And we'll try to have a cannula. We'll check the blood pressure. We don't give IM adrenaline to any patient having very high blood pressure. That can cause very high level rise of the blood pressures. So always, given the condition, you check triaging, take the patient appropriately to appropriate area, and do a positioning and ABCD quickly and treat the patient. Then we can take the quick history and rest of the examination. That save the time, that save the life. After that, we do ongoing care. So the patient may be in not appropriate of illness. So always reassess, 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 and then depending on the patient condition, we can decide what is the disposition. Is this patient in the acute cubicle? Is this patient said can we go to the general ward or ICU, or we need to transfer the patient? So always we should do in a structured way. So that is the most important 5 steps to today's lecture: the research protocol, the triage, initial stabilization. Third one is the direct history and examination, and the specific treatment and ongoing care. So if you have any questions, we can ask and discuss. So in the absence of the questions, I would like to go to the winding of my presentation. The take-home message is, always you should have the research protocol. The systemic approach, it is easy to learn and readily easy to recall under stressful conditions. And that carries 5 stages: the triaging, initial stabilization with positioning and ABCD, and then we go for direct history and examination, then start the specific treatment, then consider ongoing care. So thank you very much for your participation and listening to my today's presentation.
Thank you so much, sir, for that very elaborate lecture. And as you mentioned at the beginning of the lecture, we might find critically ill patients irrespective of place and time of our specialty. And as doctors, we must be equipped to handle such situations. So I'm really grateful for you in bringing up this topic today. And I'm sure we will arrange few more lecture series with you, sir, in regards to this topic. And I thank you so much again. And so we'll be meeting you again with such important lectures in the future. Until such time, have a good day. Take care.
Thank you very much.